I don't know how to edit. Hi, this is Dr. Stu Fischbein, yeah, and I'm Dr. Ros Drake, and we're on Kanawa Beach on the North Shore on Oahu. Look at that stunning location, and behind us, some gorgeous mountains.
This birthing work is hard stuff.
Yeah, it is really tough. If I knew it was going to be this tough, I would have started sooner. So I just have a few questions for Dr. Stu, and we're probably going to run through them really quickly because we're in a stunning location.
Hi everybody. Welcome to Oahu.
Absolutely. We've just completed a 2-day reteach breech seminar, which was amazing, and I'm going to be talking to Dr. Stu's administrator about getting him over to Ireland so we can start teaching breech vaginal birth to the midwives and birth keepers there and bring it as an option to the mamas there. So I have a few questions, but if we get bored, we're just gonna
we'll wander off script. Yeah. We'll wander off script for sure.
Yeah, absolutely. Alrighty, so this is a question I asked you yesterday and you did answer in the course. But do you recommend body work to encourage babies to go vertex or leave them be?
In an ideal world, body work is always good. Not necessarily to turn the baby, but just to have the mother's pelvis in the best possible condition for being loose and, pliable for labor. But because of the world we live in, when you have a breech baby at 34, 35 weeks, or even a little sooner maybe, probably doesn't hurt to start to see your chiropractor and get Webster technique done. Maybe go see acupuncturist, get moxibustion, go to the Spitting Babies website. It's like this whole thing that we talk about every time we have a breech baby. But we do these things that are sort of frantic because the only choice we have if the baby doesn't turn is to have a cesarean section. And that seems to be the guiding principle, as opposed to if the baby wants to come breech and it meets the basic requirements for a breech birth, which aren't many, then let the baby come breech. But we just don't have enough practitioners, and the people that are running the medical model of obstetrics in your country, in my country, have rather given up on the skills that make my profession unique. So I think that ultimately body work is always good, but for the mom who's facing a breech decision, sometimes it's the only choice they have.
Yeah, absolutely. And that's why we need to be talking about breech vaginal birth and getting the training out there to give it as a choice, because mums otherwise have no choices. So again, this is a question I asked you over the weekend. Are you concerned about the possible congenital hip dysplasia with breech babies? You'd said you hadn't really seen an increased relationship between the two, even though that is a risk factor for CHD.
Yeah, I know it's reported that breech babies, especially frank breech babies, are more likely to have congenital hip dysplasia. I, in my limited series, have not seen that very commonly. These things tend to get propagated down. Everybody says, well, breech baby, hip dysplasia. Maybe there was a paper that came out that said that. I don't know. I'm not really a pediatric expert, and I don't see babies beyond the first 6 weeks or so postpartum. So I don't know what happens to a lot of them long term. But I really, again, think it's a little bit one of those things that's blown out of proportion. It was something that was reported, and then it gets repeated, and it gets repeated, and it becomes legend. And I'm not so sure that it's true. Not being a diagnostician in that, I don't know whether or not that's something that's easy to pick up by your pediatrician, by your chiropractor, by your midwife in the weeks that follow birth. The idea, we talked about this yesterday, about every breech baby getting an ultrasound, or some people are saying every baby should get an ultrasound of their hips, and why not? If you're a for-profit organization, sure, you're going to recommend that. But I don't see that that's really necessary in real life.
Yeah.
Excuse the helicopter going over.
Little biplane when they're in airfield. Like you see some really cool videos and photos of babies, you know, those few days after being born, you can tell they were breech because, you know, the legs are still stuck up.
The Frank breech ones,
Yeah.
they're very cute.
So, you know, from the chiropractic profession, I'd say if any baby was breech, regardless of CHD, is go and get them some body work done to help ease out that hip tension, even if it hasn't led to actual dysplasia.
Yeah, in our community in Southern California, we encourage all our parents to have craniosacral work or a chiropractor work, not only on the baby but also on the mom as well. Not everybody can afford it, not everybody gets it done, but certainly it's something that should be part of the prenatal counseling and package to inform them that, yeah, these are good things to do. You know, babies are in that position for a really long time in the same position, but obviously nature designs them that way.
Yeah.
So to assume that just because they're in that position they're going to have a problem is probably denying Mother Nature, and I think that babies with true hip dysplasia do probably present themselves over time, and I don't know if it's something that you have to catch early. You probably know more about that than I do.
Yeah, I'm not a pediatric chiropractor. I decided a long time ago babies weren't my thing and concentrating on the moms, but as I mentioned to you yesterday, there is a genetic predisposition of CHD in Ireland because of the sort of a Celtic gene. My youngest had CHD, but she wasn't breech. She was my second born, so she had none of the risk factors. So, you know, CHD would probably be more of a concern for some of the mums, but when it comes to breech, the initial concern is the limitation of birth choices rather than, oh, I want to turn my baby because I don't want it to have CHD.
Oh, for sure, for sure. Do you have any idea why it's more prevalent in Irish?
No, it seems to be Ireland, kind of like Wales and Scotland, so that kind of Celtic, yeah.
You think if it's that prevalent, there must have been a reason for it biologically centuries ago, or
inbreeding.
Yeah. Inbreeding. Okay.
So this is a question I got from a friend of mine who's a women's health physio, and she wanted to ask, does a breech vaginal birth have a different impact on the pelvic floor versus a vertex birth?
Not that I know of.
Yeah.
I mean, it's a pretty simple answer. Women will describe their breech birth as being easier than their head down birth, harder than their head down birth, or really no different than their head down birth. And as far as recovery goes, I personally think that, you know, I can't state what happens to the pelvic floor, but I think the pelvic floor is designed for this. But as far as perineal injuries or injuries to the levators or things like that, I think you see far less in a breech birth than you see in a head down birth. And that may be because of the practitioners who know how to do breech maybe are just more attentive to the perineum.
Yeah.
I don't really know why that is, but I don't think it's a matter of affecting the pelvic floor any differently. And maybe you could say, well, why? Maybe it was my baby breech because there's something wrong with my pelvic floor. I don't think that's the case either. I mean, I've had moms who are extremely fit, CrossFit marathon runners who have breech babies, but I've had them have head down babies too. And I don't think there's an excessive amount. Again, everything that I'm telling you doesn't reach statistical significance. It's anecdotal because even though I've done a lot of them, it doesn't reach a statistical significance.
It doesn't go into the
So it's essentially based on what we would call level C evidence or opinion, right?
Yeah, and you know, so over the weekend you were saying only about 20% of breech babies will actually need assistance from the service provider. That the going kind of advice is hands-off breech birth. So do you think that's one of the reasons why there will be less perineal damage? Is actually there isn't the coach pushing, there isn't the
that's true.
That
well, I don't know that there's less. I mean, I don't think I said there was less either, did I?
Less coach pushing?
No, less perineal damage.
Yeah.
Right, I thought you were taking less pelvic floor damage. Yeah.
No.
Yeah, maybe. We don't do coach pushing. We're not often putting our fingers in and massaging the perineum posteriorly. We really do leave the baby alone. We really want to touch the baby. We don't touch the mom. But that's the midwifery model. That has nothing to do with Dr. Stu or doctors. I credit most of what I know right now to the people that taught me this well after I finished my residency program.
Yeah.
Because I didn't learn anything about normal birthing or about hands-off or about natural birthing or trusting nature from the medical model. It's the opposite, right?
Yeah, absolutely. I had someone tell me the other day that less than 1% of hospital births are now 100% physiological, which is just, it's barbaric, in my opinion.
Yeah, I mean, we talked about this yesterday at the conference. Is how is there such a thing as a woman that's low risk in the medical model?
Yeah.
Because they're constantly, during your prenatal visit, they're constantly telling you things that even if you don't really have any medical problems, they're planting seeds of anxiety and doubt in you that then can make labor more dysfunctional. Or they're calling you because you're a young mother, or you're an older mother, or because your husband's tall and you're small, or because you're a little over, your BMI is a little high, or you're slightly hypothyroid, that they're labeling you with all these labels and calling you high risk. So every woman that goes through the medical model, starts to have a problem list. In our model, we sort of got rid of the problem list. We call it a diagnosis list, or we call it a whatever, but we don't call it a problem list. I think I told that anecdote before, which I think is I think I'd like to tell your listeners. I got caught on this last year. I was taking a history from somebody. When you take a history from a new client, you talk about what medicines are you on, what are your allergies, what's your past medical history, what's your surgical history, and all that stuff, and then the current reason that you're here in the office. And when I got to past medical history, I asked this woman if she had any other medical problems, which is the way I've been saying it for 40 years. And she looked at me and she said, "What's the first one?" And I realized when I say any other medical problems, I'm implying that the fact that you're pregnant is the first problem. And so that came out of my medical training, and I wasn't even aware that I was doing that. So now I've tried to change that. I still slips out sometimes.
Yeah, we all do. It's the language is so important. I think even more so in the obstetric world. Great.
Well, it's about, I mean, how we view things and how we feel safe is important for all of us at all the time. But if you're having your appendix removed and you're sort of nervous, well, you know what? You're going to have general anesthesia. You're going to be out anyway. But when you're having a baby, if you're nervous, or even if you're nervous all through the pregnancy, you're creating a new human being, and you're bathing that new human being in your humoral, hormonal, neurotransmitter world that's filled with anxiety and fear. And so what does that do to the epigenetics and the programming of your child, and how does it affect it? And again, we don't know that exactly, but we can only surmise that it probably makes a difference, and yet it's something that nobody gives any credence to. Remember, the only thing that matters is
the baby in the bassinet.
Baby in the bassinet,
yeah.
Right.
And the research is starting to come out about how the woman feels about her birth, and it's showing the results for the mother. But there are mums, you've come across them, I've come across them, who 10, 20, 40 years later could still be traumatized because of the birth that they went through.
Yeah, women remember the birth of their baby all their life.
Yeah.
I mean, all their life. They may not remember the names of their kids, but they'll remember the birth of their baby. It's one of those events that they have, and a lot of them, I'd like to give them all better memories. A lot of them don't have very good memories.
Yeah. I know you've recently come across Dr. Rachel Reed and Katie James of the Midwife's Cauldron. And Dr. Rachel Reed released a book recently, and it's the rites of passage of childbirth, and it compares physiological birth with the medicalized model, and it's a beautiful book because it talks about the empowering experience of a woman going through birth, and it can be such an empowering and magical experience that when that is denied to a woman, she doesn't realize how powerful she can be. So if no one's read that book, I would highly
Is Rachel Reed, is she Midwife Thinking?
Yes.
Yeah.
So,
that was one of the first websites I encountered when I started to really dig into stuff.
Yeah.
Right. She's got some great stuff.
Oh, she's amazing.
Right.
Absolutely amazing. Alrighty. Not sure if you're going to know about this one, but it was a question that came up. So about lotus birth during a C-section. So lotus birth is when
Tell everybody.
Yeah. Okay. So lotus
I'm
birth.
just holding it and sparing your arm.
My arm.
Your arm was
Just getting a workout.
The camera was drifting. I could tell, so I took over.
Beginning to shake.
Yeah.
So lotus birth is when the placenta is kept attached to the umbilical cord and attached to the baby until it eventually naturally drops off, which could be a few days. And
yeah, about 5 days usually.
Yeah, there's a ceremony that, essential oils or flower petals, because I think you can start to smell maybe.
Oh yeah, you have to like prepare it in some way. I don't know much about lotus birth.
I don't know much about it. This
right.
lady.
I always wonder why people want to do it.
Yeah.
Right.
Yeah,
because they think it's like more natural that way, but other mammals that they don't. No one comes in and cuts the cord in another mammal, but other mammals don't carry their placentas around for 5 days.
No.
You know why they don't carry their placentas around for 5 days?
Predators.
Yeah.
Yeah. They would chew
they
it
fall
off
off like almost immediately. By the way, when they fall off almost immediately, you notice that the baby isn't gushing blood. The baby deer or the baby horse isn't gushing blood from its umbilicus.
Yeah.
Those vessels, I think they contract very quickly. But we're always afraid, so we got to put that big plastic clamp on there, the big rubber band. People that want to do lotus birth at a cesarean section, it certainly can be done. Right? It can be done. I mean, the problem is that with a cesarean section, the baby's generally not going to go directly to the mother, even with a gentle cesarean, it's not going to necessarily happen that way. So, you want to take it?
Yeah.
Yeah. Okay. So, but yeah, the baby can come out. There's no reason to rush and clamp the cord. The problem is that, well, not the problem. A problem is that generally, because the woman is open and bleeding a little bit, they're going to want to get the placenta out relatively quickly. So they reach up with their hand and they shear the placenta off with their hand, and it comes out. Now you've got the placenta and the cord and the baby, and you can hand that all off to the circulating nurse and let her do her thing with that. And then it could be done. The question you got to ask yourself again is, why?
Why? Yeah.
What's the reasoning for doing it? If there's a good reason to do it, and you want to do it, there's no reason you can't ask your hospital to do it.
I think the fact that even getting optimal cord clamping in a hospital setting is difficult enough that for them to help to facilitate you to have a lotus birth.
Well, the problem is if you're thinking that it's going to give you longer delayed cord clamping, you're wrong, because what's going to happen is the baby's going to come out, and even if they don't put a clamp on the cord, within a not too long a time, they're going to reach up and just pull the placenta out anyway. So what's the point? Stop. Yeah. So what's the point of keeping the baby attached at that point? If they were going to let the baby sit there for 3 minutes, 4 minutes, 10 minutes, whatever, and be attached, that's okay. But the problem is then you've got an open wound and you've got bleeding going on, and you really don't, you want to close that up. That's what we're taught.
Yeah.
I don't know. I wouldn't know anything different than that.
Yeah. I think. You're more likely to be able to get that lotus birth if you're having a home birth and have a home birth midwife and maybe a doula there. That's more likely the situation where you're not carrying it around and you can just lie on your bed with the placenta in a bag or a box next to you, whereas in a hospital in a ward with could be up to 10 other mothers around you, they may not appreciate your placenta next to you.
They will not appreciate it. They won't know what to do. Right, and their eyes will roll, and they'll make because when people are uncomfortable with something, they have to find a way to make themselves comfortable with it. So often it's a little bit of belittling or whatever. So we won't go there.
That would be a whole other. So we talked about this briefly, but about polyhydramniosis. So too much amniotic fluid. I've seen that, whether in mums, when they've had multiple births and therefore the uterus has been stretched more often, or the polyhydramniosis, so the baby has more space and they're kind of swimming and bobbing, that they're more likely to be in a breech position.
They're more likely to be in an unstable lie. Even if they're head down, they're not necessarily engaged. Right? Yeah,
they're bobbing.
So what's the question about that? That's the question?
What's your opinion? Do you think polyhydramniosis is that an actual issue with breech?
Well, I don't think it's an issue with, in our model, it's not an issue. The issue is we want to let nature see what happens to it. So a lot of times if they have really true polyhydramnios, but there's no anomalies of the baby or there's no reason for it other than the baby's got AFI that's really high, like 30 or something, when that woman's in labor, if the presenting part really isn't clear, but it's probably the head or it's probably the butt, then what we were always taught in residency was at some point you do something called needling the membranes. And needling the membranes is where you take like a tiny little spinal needle and you just poke a hole in the membranes. With your fingers, you slip the needle between your fingers and you poke a hole in and pull the needle back out. And then you keep your fingers there very, very slowly and let the water slowly leak out, and your fingers can guide the presenting part as it comes down.
Okay.
And rather than having that sudden rupture of membranes where you have this huge gush of fluid,
yeah.
And then you could theoretically have a cord prolapse, or you could really have a weird malpresentation, or a limb could come down that isn't supposed to come down, or the baby could be in a transverse lie. This way you're guiding it down. Again, it is a bit of meddling, and in nature, if you probably did nothing, most of the time it's going to come out okay. But again, I still have a lot of OB left in me, even though I've been working on getting rid of most of it. And that would be something that if I had a client that I thought had an unstable lie because of poly, and she was in labor and she's 5 centimeters and this bulging bag of waters, and you don't even know what's presenting, is to potentially like needle the membranes and do it in a controlled situation as opposed to just at the very end where it breaks at 8 centimeters and out falls the cord.
Yeah.
Right.
Yeah, I'd never heard of that. That's cool.
Needling?
Yeah.
Yeah.
I don't think that's just something that's very commonly done in Ireland.
I don't know. I mean, this is just what we were trained to do, and I'm assuming it's still done here. And it makes really good sense to have it done in a controlled system if you want to give the mother the best chance to not have some sort of weird thing happen.
Yeah,
right.
Yeah, and it becomes an emergency situation.
Yeah, and a lot of my midwives would be shaking their heads right now and say, no, you just leave them alone. The nature's designed this thing. It's going to be okay. But it's potentially going to be a problem and then you can't avoid by doing that. So
that sounds cool. This was a twin mom, a friend of mine. She's about 26 weeks, twins, and while twin one is vertex at the moment, she's wondering if twin one was to go breech. Now, for you, that wouldn't be an issue, would it?
No, it actually, we discussed this yesterday.
Yeah.
You saw that. We did when I did my twin lecture. We talked about what if twin A is breech, and the world literature actually supports delivering a first twin breech without any increase in morbidity or trauma by any baby that's over 1,500 grams when the first one is breech. Problem is nobody has the skill or willingness to do breech delivery. It's so much easier, expedient, economically, medical legally, to just say, oh, your first baby's breech. Nobody does breech deliveries anymore. We can just schedule you for a C-section before you go into labor. And because if you went into labor, then maybe the cord will fall out, or maybe the foot will fall down, or they'll just keep propagating these scare tactics to get people to do what they want to do, which is a form of coercion, which is really never acceptable.
Yeah.
An ethical thing to do would be just for a doctor who, by the way, sometimes you have surprise breaches and a doctor doesn't know how to do breaches, stuck with that. But if you have twins, when you have twins, 10 weeks, 12 weeks, 13, 15 weeks, you now know you have twins. If you're an obstetrician and you're not comfortable with one or both of the twins being breech, why are you caring for that mother? Why you're not an expert in twin delivery? Transfer her care to somebody who is.
Because I don't know what the percentage chance, but when you've got twins,
we talked about it's over 50% that at least one of the twins is going to be breech.
Exactly.
We went through all that stuff yesterday.
I just couldn't remember the
stats. It's over 50% that one of the twins will be breech, and 13% I think that they're breech. So, twins is something that if you're not comfortable with it, and if you think that I'm going to tell you that you need to have a C-section, we need to schedule it at 37 weeks, whatever else, you're not a twin expert at all. And you should have no business taking care of twins.
Yeah. And
you have time to refer that person out. But there are things that prevent you from doing that, and one of the main ones is ego.
Yes.
They don't do that.
But
breech first twins, again, if they meet the same simple criteria for a safe singleton breech delivery, there's no reason that a first twin breech can't be delivered.
Yeah, this mom is a first-time mom, so I think she's coming up with a few obstacles to try and achieve.
Well, the biggest
vaginal birth.
obstacle that everyone's finding, and your listeners will find, is finding somebody willing to support you.
Yeah.
That's going to be the biggest obstacle. But it's not wrong. When people tell you that it's wrong, or when people tell you that it's crazy, they don't know anything. Yeah, people who talk like that don't know anything. People that are confident in their position don't have to resort to pejoratives and scare tactics to get you to understand those things.
Absolutely. Thank you. So I'm not sure if this is a question you can answer, but I was asked tips for controlling blood sugar with gestational diabetes when laboring at home.
So the academicians in my profession aren't going to like my answer, but if you're a gestational diabetic and all through your blood sugars have been fairly well controlled on diet throughout the pregnancy, don't even bother checking them in labor.
Yeah.
And if you want to check one right after you give birth to see what it was, you could do that, and that would help to determine whether the baby's going to be at risk for hypoglycemia. But why are you bothering?
Yeah.
Whether your blood sugar is 80 or your blood sugar is 130 or 140, you're not going to do anything different with a gestational diabetic. They're not on insulin. You're not going to give them insulin. And what we do with all our diabetics at home, whether they're gestational diabetics or twins, or if they are type 1 diabetics, is we have frozen donor milk in the freezer.
Okay.
So on the rare case where the baby is showing signs of hypoglycemia, it's jittery, it's breathing too fast, whatever, we would then get the baby on the breast and use what's called the supplemental nursing system to just like slowly inject a little bit of milk as the baby's sucking away on the mom's breast, getting mom's colostrum and all that good stuff, and then helping the baby to keep its calories up. So gestational diabetes, again, is one of those things it's on the problem list, but it's really not a problem for most moms. I mean, if you have poorly controlled gestational diabetes, that's a different story, because then you can have a macrosomic infant and that sort of thing. But if you have gestational diabetes and your doctor or your midwife is taking care of you, and really you can almost always control that with diet.
Yeah.
And in the midwifery model, we rarely see gestational diabetes. Do you know why?
They're not tested.
No. But we don't test with the 1 hour post 50 gram glucola thing.
Okay.
We use 1 hour postprandial. I don't really care how a woman responds to 50 grams of sugar, which she's not going to normally eat. I want to know how her body responds to a normal meal for that woman. So eat your 2 eggs and toast and your orange juice for breakfast, and come in and we'll draw your blood an hour later. But we don't see gestational diabetes because the midwifery model has time in their prenatal model in their long prenatal visits to discuss nutrition.
Yeah.
And if somebody isn't eating well, we work really hard to try to change that pattern. Can't always do it, but we try really hard to do it.
No.
Right.
Have you heard of Lily Nichols? She's the American dietitian nutritionist. She's got the book Real Food for Gestational Diabetes.
I haven't, and I feel bad when somebody who's probably worthy of me knowing them and I don't know them. So, but I don't. Yeah,
she's a big advocate for pregnancy nutrition and has lots of online courses, and her books are great. And
well, nutrition is, we got a parasail there. Nutrition is something that all of us should have, whether we're pregnant or not. I'm bad at it. Daniela's great at it. She eats really healthy stuff, and I don't. But my dad lived to be 96, eating salami and smoking cigars. So it's all good. It's all good.
Okay, so last question. Increase in free birthing in Ireland, which I think is happening around the world because of the lack of birthing choices in the medicalized model for moms. If a mom is planning to free birth and either with a planned or unplanned breech, is there anything she should do or not do to educate herself?
She should watch a lot of videos, and YouTube is loaded with videos, and you can see that most of the ones on YouTube are going to be smooth, beautiful deliveries. And she should get familiar with what's a normal situation, what's not a normal situation. And again, like we said, I don't know, I'm making up the number, but about 80% of breeches, when you're in all fours, if you leave them alone, they're going to deliver on their own. They're not going to need any help. Yeah. It's those 20% or whatever number it is that need help. So as a practitioner and a supporter of women's choices, I'm not a condoner of free birthing with a breech baby, but if people choose to do it, I think the best thing to do is read, watch videos, so you know what to do, or have a practitioner that is available to FaceTime. We'll wait till this helicopter goes by.
Now we have a military helicopter, I think.
Where'd it go?
There we go.
Yeah, that's definitely a military helicopter.
Yeah.
It's ferocious looking. you don't want to mess with that guy.
No.
Right. It's got four. It looks like it's got 4 guns on it. Yeah, Oahu is loaded with military bases. So,
Absolutely.
I spent the morning today at Pearl Harbor, which was exciting for me because I'm a history buff. So I had a great time. went to the USS Missouri, and I went to the Air Museum and saw a lot of the types of aircraft that were around during Pearl Harbor. It was pretty interesting.
We're going to head there in the next couple of days. So that's all my questions.
So did we finish that question? Oh yeah, free birthing.
Yeah, free birthing. So just go and educate themselves.
And potentially have somebody able to consult on FaceTime.
Yeah.
Right.
Yeah, absolutely. Well, there are my questions, but I have one final thing I want to do. So I'm going to turn it this way and... Oh, I can't turn it around. Do you just want to hold that for a sec?
Yeah.
Because I have a little gift for you.
Oh.
I'm
gonna make your viewers dizzy. I'm gonna make your viewers dizzy. They're all gonna get seasick.
I'll take this, and this is for you, all the way from Ireland.
Uh-huh.
I told some of my patients about this, and they got very excited. So that's pronounced Sheila na gig.
Sheila na gig.
Yeah, do you want to read that out?
Perhaps we shouldn't be surprised that Sheila na gig can be translated as old hag of the breasts. Whilst grotesque and obscene to many in the modern day, this little gargoyle-like figure was likely once seen as an immensely powerful and capable of warding off dangerous spirits, hence her familiar spot on early Irish churches. Oh my gosh. Archaeologists disagree, there's a shock, as to whether she is a genuine Christian medieval figure, when the horror of the female body was so frightening as to deter demons, or a vestige of a far older Irish paganism. If pagan, it is likely that her open vagina was a symbol of a link between worlds, and so the entrance to churches may also have been seen in a similar fashion. There is also folkloric evidence of laboring women using Sheila figures as birthing talismans. The clear reality of who and why she was is lost to time, but for modern Ireland, Sheila has been reclaimed as a symbol of rebellion. Her unapologetic display now a protest of self-acceptance.
Yeah.
Ah.
So this is made by a woman in the west of Ireland.
A display of protest.
Yeah.
Oh, look at her. She looks very Hawaiian, actually.
Yeah. So it's a Sheila na gig has a big vulva that she's holding open with her hands, and the way it's being brought back in Irish culture is as a birthing talisman and female empowerment. And this was made by Sav of Erin.
Farther back.
There we go. Alrighty.
It'll all be backwards, but that's okay.
There we go. So.
Wow. So do I wear this around my neck?
You can, or now I think you might not be going into private practice again, but my idea was it could go in your birthing kit bag and travel with you when you go round to baths.
Does it get a traction when it goes through airports? Will I get in trouble?
I think it's rock. I think you'll be okay.
Okay.
Yeah.
Thank you. Thank you very much.
More than welcome. So, bye guys from Oahu.
Mahalo.
And I'll post it soon. Bye.